Hello friends, today we are going to discuss about the rhabdomyolysis. This was the also question which was asked in DRNB critical care exam in December 2022. So rhabdomyolysis is basically characterized by skeletal muscle disintegration and the release of myoglobin and other intracellular proteins and electrolytes into circulation. Typically, creatine kinase levels are markedly elevated and muscle pains and myoglobinuria may occur. The condition ranges from asymptomatic to life-threatening injuries, mainly because of hyperkalemia and acute kidney injury. So rhabdomyolysis can be traumatic and non-traumatic. So according to the literature, the causes are most commonly it is caused because of the ischemic by vascular obstruction. Then it could be caused because of the crush injury, which is caused by trauma. Then in certain cases, it is associated with sepsis, heat stroke, hyperthermia, and in rare cases with hypotension. So alcohol is commonly associated with rhabdomyolysis. Coma, whether from alcohol or from other cause, can lead to prolonged muscle compression and ischemia. So alcohol is also damaging the sarcolemma directly, which cause myopathy, leading to non-traumatic rhabdomyolysis. In addition to causing rhabdomyolysis in its own right, the chronic abuse renders the muscle vulnerable to the further damage. So rhabdomyolysis is common complication of patient presenting with recreation drug use. 24% of patients presenting with cocaine-related disorder in one emergency department develop rhabdomyolysis. In another study, 60% of emergency department patients with rhabdomyolysis tested positive for cocaine and amphetamine use, and 45% were noted to be clinically intoxicated. So adverse drug reaction are the important iatrogenic cause. The use of statin is widespread and this class of drug can lead to rhabdomyolysis secondary to myopathy. Fortunately, fatal rhabdomyolysis among statin users is rare, with reporting rates lower than one death per million prescription. So the next culprit of rhabdomyolysis is anesthesia. Anesthesia obscures the pain and the paresthesia of, and it is causing the paresthesia of prolonged muscle this is anesthesia will cause the obscursion of the pain and paresthesia. The prolonged muscle compression leads to the that disturbs the conscious patient. So the combination of surgery and anesthesia can expose the patient to muscle injury and rhabdomyolysis. So risk factors which are involved in when we are giving anesthesia is prolonged immobility, use of tourniquet, non-invasive arterial pressure cuffs, and the poor perioperative position. So the compression of discrete muscle group may occur in the lower limb in the lithotomy position or in pressure points during pronation. So particular care to prevent the localized pressure effect must be taken in these at-risk patients. So the incidence of rhabdomyolysis increases after the onset of wars and natural disaster. Now we will summarize the causes of rhabdomyolysis. So the cause of rhabdomyolysis is mainly divided into traumatic and non-traumatic. Traumatic cause includes crush injury, trauma, which may occur due to any natural disaster like earthquakes, collapsed building, or any road traffic accident. Then it may occur because of the compartment syndrome, which is associated with the alcohol associated immobility and prolonged collapse. Then it may then some perioperative procedures and prolonged tourniquet use. Some electrocution injuries are responsible for the rhabdomyolysis. Now, the non-traumatic causes include exertion, that is a seizure or strenuous exercise, body temperature changes like malignant hyperthermia, neuroleptic malignant syndrome, and hypothermia. Then genetic causes defects involve ranging from disorder of glycolysis, gluconeogenesis to disorder of mitochondria. Then drugs and toxins like statin, alcohol, heroin, cocaine. And infections like influenza A, B, Epstein-Barr virus, HIV, Streptococcus pyogenes, Staphylococcus aureus. Then metabolic and electrolyte disorders like non-ketotic hyperosmotic state, diabetic ketoacidosis, and in some cases it is idiopathic. Now about pathophysiology, rhabdomyolysis involves either direct sarcolemmic injury, which occurs because of trauma, and it may occur because of the depletion of ATP within myocytes. So ATP stores maintains the ionic gradient across the cell membrane, including calcium ATPase pump. So whenever there is a depletion of this ATP, it impairs the function of this calcium ATPase pump, which results into the increased sarcoplasmic calcium level, leading to the persistent contraction of myofibrils. So this sustained contraction leads to further energy depletion, activation of calcium-dependent neutral protease and phospholipids, and eventual disintegration of myocytes. Now, metabolic derangement. After myocyte injury, intracellular contents are released into circulation. So it leads to the hyperkalemia, hyperuricemia, hyperphosphatemia that can all develop rapidly. So high levels of phosphate will bind to calcium. It leads to the calcium phosphate deposition in soft tissue. In addition, the calcium is lost from the serum by entering damaged muscle cell with resultant hypocalcemia. So ischemic muscle is forced to utilize anaerobic metabolism via conversion of pyruvate to lactate, and that results into metabolic acidosis. So the combination of this hyperkalemia, hypocalcemia, and acidosis is particularly dangerous. So hyperuricemia is caused by the metabolism of purine from disintegrated cell nuclei. So during the recovery phase of rhabdomyolysis, about one-third of patients develop hypercalcemia. This may occur due to release of vitamin D stored from the injured muscle, providing substrate for production of excess 125 dihydroxyvitamin D. So hypercalcemia may further exacerbate it if excess calcium is administered during acute hypocalcemic phase. Myoglobin is dark red heme containing protein that stores and transports oxygen in the muscle. Only small level of myoglobin are normally present in the plasma. At normal level, this small amount of myoglobin is bound to plasma protein and very little crosses the glomerulus. So myoglobin has a small molecular weight that is easily filtered. When this transport mechanism is overwhelmed, the renal threshold for free myoglobin is exceeded and myoglobin appears in the urine. Now about the relation of the AK and the rhabdomyolysis. During intensive care, the reported incidence of acute kidney injury after rhabdomyolysis may be as high as 65%. And it occurs as a result of multiple mechanisms, including tubular obstruction, direct and ischemic tubular injury, and intrarenal vasoconstriction. So within the tubule, myoglobin interacts with the protein that is TAM Harsfold to form brown granular cast, and this results into the tubular obstruction. This process is favored when the urine is acidic, and the myoglobin may have no nephrotoxic effect when the urine is alkaline. So tubular obstruction may be compounded by deposition of urate as a result of hyperuricemia. The heme group from the myoglobin has been implicated in the lipid peroxidation with accompanying cytotoxic effect. The scavenging effect of myoglobin in the renal microcirculation results in a deficit of vasodilator, nitric oxide, and renal vasoconstriction, which further compounding renal injury. So renal blood flow is further reduced by hypovolemia, activation of renin-angiotensin system, and addition of vascular mediators. Now the clinical manifestation and investigation. A level of suspicion for rhabdomyolysis is required in patients suffering from trauma, crush injury, prolonged immobilization. When specific muscle group is involved, the history of weakness, myalgia, swelling in the affected limbs may be obtained. Severe pain may limit the passive limb movement and there may be a reduction in the range of active. In compartment syndrome or crush injury, the muscles may be tense and swollen, leading into the nerve injury and sensory loss. In diffuse muscle injury, such as occurs with the drug, there may be general malaise with diffuse myalgia and non-specific deterioration. Rarely, patient may volunteer that their urine had changed to the red or brown color. So, commonly offending drugs such as statin, alcohol, heroin, cocaine should be identified and withdrawn. Clinical observations may initially be normal and be normalized after fluid resuscitation only to deteriorate hours later as condition progress. So regular observation including hourly urine output are required to detect any deterioration promptly. So rhabdomyolysis is typically diagnosed when the creatinine kinase is more than 5,000 units per liter. This value represents the 5 times its normal upper limit. Myoglobin level peaks before increase in the creatinine kinase. However, myoglobin is metabolized rapidly as at sites outside the kidney. This makes the creatinine kinase a reliable marker for rhabdomyolysis. So, creatinine kinase is predominantly of the skeletal muscle rather than myocardial fraction. An increase in creatinine kinase myocardial fraction represents the small amount found in skeletal muscle rather than cardiac injury. So creatinine kinase level typically peaks between 24 to 72 hours after onset of rhabdomyolysis. If creatinine kinase continue to increase beyond this period, an undiagnosed compartment syndrome should be considered. Serum and urine myoglobulin can be measured directly but is not offered from all labs. So myoglobulin is detected in the urine when the serum concentration exceeds the renal threshold of 0.5 to 1.5 mg per day and is directly visible as a reddish brown urine when concentration exceeds 100 mg. As increase in the serum myoglobulin precedes that of the creatinine kinase, the metabolism of myoglobulin is rapid and myoglobulin level may have become undetectable by the time urine levels are tested. So in addition, the intrinsic property of the assays used to detect myoglobinuria is insensitive and may also reduce the frequency that myoglobinuria is detected. So in the absence of exclude rhabdomyolysis. So they have conducted studies in 475 patients with rhabdomyolysis diagnosed by CK, creatinine kinase level and myoglobinuria was detected only in 19% of cases. So urine dipstick for the blood is positive in the presence of myoglobin and has a sensitivity of 81% for detection of rhabdomyolysis and is far frequently present than positive assay for the myoglobin. So false positive result will occur if urine red cells are present as these impair the reliability, especially in the setting of trauma. So urine dipstick is the rapid bedside test that can be used in serial manner to assess resolution of myoglobinuria, providing a useful endpoint for the fluid resuscitation. A metabolic acidosis with high anion gap is commonly reported in rhabdomyolysis associated with AK. Arterial blood gas analysis allow the monitoring of trend in pH and serum lactate that can guide fluid resuscitation. In addition, pH base access potassium level can be used to manage decision regarding the renal replacement therapy. Clotting studies should be undertaken to exclude the DIC that may occur at more severe spectrum of rhabdomyolysis. So, this is the table which showed the necessary investigation in rhabdomyolysis. So first, the obvious investigation that we are sending is creatinine kinase. And the possible finding is creatinine kinase levels are more than 5,000. Then serum and urine myoglobulin might be present. But the absence of this myoglobulin, we cannot rule out rhabdomyolysis. Then the urine dipstick will be positive for the blood. Urea creatinine will be raised because of the AK. Potassium will be high, calcium will be low, and phosphate level will be raised. So this The reason behind the rise in level of the potassium and phosphate is the uh, damage to the muscle. And this phosphate is binding to the calcium, so we will find the hypocalcemia. Coagulation studies will be prolonged. Blood gas will show the metabolic acidosis, which is high anion gap, and ECG might show the changes of hyperkalemia. Now we'll see how to manage. So early fluid resuscitation is most common measure in the proven investigation, proven in the prevention of the acute kidney injury. Large volume depletion occurs due to sequestration of the water by injured muscle. So bladder catheterization is required to monitor urine output accurately, and invasive monitoring such as arterial and central venous pressure monitoring should be considered to guide fluid resuscitation. So the target urine output should be 3 ml per kg for 21 hours, that is 300 ml per hour for 21 hours. So which fluid should we use for resuscitation? Normal saline, compound sodium lactate, sodium bicarbonate has all been used in the literature as a resuscitation fluid and have comparative merits and demerits. So compound sodium lactate may aid in urine alkalinization but should probably be avoided as it contains the potassium. Normal saline is the devoid of potassium and it is more appropriate, but it is contributing to the hyperchloremic acidosis. Volume resuscitation with polyuria should be continued until myoglobinuria is cleared and supported by negative urine dipstick blood. So next is alkalinization of the urine by administration of the sodium bicarbonate has a theoretical advantage because it is saying that this precipitation of TAM horsal protein complexes is occurring only in the acidic environment. And if we'll provide this alkaline urinary involvement, then we can reduce this precipitation of this TAM horsepower protein. But the disadvantage of the alkalinization is the further reduction of the ionized calcium that may further exacerbate hypocalcemia induced by phosphate calcium precipitation. So sodium bicarbonate may be administered as a bolus of 50 to 100 mmol to aid in the volume resuscitation. The advantage of administration of 1.26% of soda bicarb is avoidance of hyperchloremic acidosis associated with large volume of sodium chloride infusion. So the target urinary pH of 6.5 should be achieved. The evidence for use of sodium bicarbonate as a therapy to prevent AKI in rhabdomyolysis is lacking. So the next is mannitol. Mannitol has a theoretical advantage. It flushes the nephrotoxic agent through tubules, extract the fluid that has accumulated in the injured muscle and act as free radical scavenge. So the mannitol may exacerbate the hypovolemia and therefore use should be reserved for when urine output remains low despite normal. So plasma osmolality and the osmolar gap should be monitored and mannitol should be discontinued if there is no improvement in the urine output or if osmolar gap increases above 55. Other diuretics are not appropriate in this setting. All other electrolyte abnormality in the rhabdomyolysis is hyperkalemia, but among those electrolyte abnormality, hyperkalemia is the most life-threatening and it should be monitored and treated promptly. So hyperkalemic ECG changes should be treated with the calcium gluconate, that is 10 ml in the 10% of concentration. So further, to reduce the level of the potassium, we can give insulin plus dextrose and nebulized salbutamol. Every hypocalcemia should not be treated until the patient is symptomatic or in the presence of hyperkalemia, as normocalcemia usually occurs spontaneously. Renal replacement therapy should be reserved for the management of hyperkalemia, acidosis, and volume. Now, rhabdomyolysis in trauma. European Renal Based Practice and Renal Disaster Relief Task Force of International Society has produced the recommendation for management of crush victims in mass disaster. It describes the basic saving intervention in disaster fields such as early fluid resuscitation, extrication, and medical and logistical recommendation that apply to major disaster. So, where compartment syndrome is suspected, the initial management should focus on prompt diagnosis and the relief of compartmental pressure. External pressure from dacing, cast, and the rubble at trauma scene must be removed. Oxygen should be administered and analgesia should be offered as a pain relief, and it is often offered out of proportion to the injury sustained. So, hypotension should be avoided as it further reduces the limb perfusion. And urgent fasciotomy is commonly a definitive therapy and should be performed as early as possible. Delay in performing a fasciotomy increases morbidity, including need for amputation. After fasciotomy, the patient should be closely monitored with the serial CK levels and hourly urine output to detect the impending rhabdomyolysis and AK. High-risk patients with multiple injuries should be cared for in critical care environment. Medical and surgical management of patients with established rhabdomyolysis should occur simultaneously. Intensive care unit mortality for rhabdomyolysis has been reported as 22% without echo and 59% with echo. However, the majority of survivors recover good renal function. Thank you guys for paying attention.